Hello everyone, my name is Sunil Kapoor. I am a cardiac electrophysiologist at the Brigham and Women's Hospital, as well as instructor at Harvard Medical School. And I'll be talking today about atrial fibrillation and other common supraventricular tachycardias. I have no disclosures relevant to this topic. So just taking a step back, the cardiac conduction system is relatively complex yet elegant in the way that the electrical signal that conducts and has an electromechanical association to tell the heart when to beat goes through a very circumscribed path. As we all know, it starts from the sinoatrial node, goes through intranodal fibers into the atrioventricular or AV node, and then down the His-Purkinje system. Anywhere along this path, disruptions can occur that can result in arrhythmias, either bradyarrhythmias or tachyarrhythmias. What we'll be talking about today are supraventricular tachyarrhythmias, meaning that the disruption in the cardiac conduction system occurs down to and including the AV node. Anywhere from the sinus node to the AV node can result in a supraventricular tachycardia. There are other ways to describe arrhythmias, wide complex or narrow complex, based on the EKG, hemodynamically stable versus unstable based on the clinical picture, and oftentimes determining whether someone has a supraventricular tachycardia is difficult based on clinical markers. But pathologically, in the way we classify them is based on where the pathology occurs. And for today's purposes, we'll focus on anything above and including the AV node. Now, the arrhythmias that are in this family start with atrial fibrillation, and we'll spend most of our time talking about that today. It's the most common clinical arrhythmia and by far the most important arrhythmia that we are forced to take care of in our aging patient population. So we'll spend most of our time talking about the basics of AFib. We'll spend some time talking about its closely related cousin, atrial flutter, which, as we all know, goes hand in hand with many of the atrial fibrillation patients. And then we'll spend some time towards the end talking about other paroxysmal supraventricular tachycardias. There are a number of different mechanisms that can result in a supraventricular tachycardia outside of atrial fibrillation, but the three most common ones that are encountered in clinical practice are atrial tachycardias, AV nodal reentrant tachycardias, or AVNRT, and AV reentrant tachycardia, meaning a supraventricular tachycardia that utilizes an accessory pathway, oftentimes described as Wolff-Parkinson-White syndrome when there is a manifestation of the accessory pathway on a surface electrocardiogram. We'll wrap up with a few questions. So the basics of atrial fibrillation are familiar to most of us. Atrial fibrillation, as we mentioned before, is the most common clinical arrhythmia. It occurs when the normal regular impulses from the sinus node down to the atrioventricular node are overwhelmed by disorganized electrical impulses that often take a haphazard or circus-like movement. This results in a clinical picture of an irregular heartbeat, as well as a very characteristic surface electrocardiogram. The electrocardiogram's hallmarks are the irregular RR intervals, which is a manifestation of variable entrance through the AV node of these haphazard circuits down to the His-Purkinje system, resulting in a QRS and a heartbeat, as well as the lack of organized electrical activity, meaning the lack of the P wave seen here at the bottom strip, which is no longer present in the top strip. The reason we care about atrial fibrillation, and we'll spend most of our time on it, is by far the most common sustained arrhythmia. The prevalence is somewhere around 3%. And this prevalence is only growing largely because the strongest risk factor for atrial fibrillation is age, and we, as we all know, have an aging population. The incidence approximately doubles with each decade of life after the age of 55. For that reason, it's relatively rare to see atrial fibrillation in patients less than 40, but relatively common to see it in octogenarians and beyond. It's expected to affect 1 in 4 people over the age of 40. So it is really something that we do and will see more and more in our aging population. It's not only an epidemic here in the United States, but kind of a pandemic throughout the world. This plot here shows the prevalence of atrial fibrillation across regional territories throughout the world. What's shown is the current estimated prevalence of AF in the smaller blue dots compared to the 2050 estimates of AF in the orange circles. And what we can see is throughout the world, the prevalence is dramatically increasing or predicted to increase. This is not simply a problem of the US and Europe, but throughout the entire territories that are described here. This is probably even an underestimation of what is going to occur because we are getting better and better with modern technology, watches and patches and Fitbits and so on, at picking up irregular heartbeats that lead to the diagnosis of atrial fibrillation. The aging population with increasing risk factors for atrial fibrillation means that this is an arrhythmia that we're going to have a lot more of, and with modern technology, we're going to diagnose it a lot more. This is a problem that's not going away. In order to try and understand why we have the problem, what's the etiology of atrial fibrillation, and why it's growing, many people have spent a lot of time trying to look at the fundamental basis of atrial fibrillation. People have looked at various different levels of pathology with regards to the genome, the transcriptome, the proteome, the metabolome, the omics, if you will, of what causes the pathology. There's also been identification of a number of different environmental risk factors for atrial fibrillation. And largely, have found it difficult to pinpoint exact etiologies of the disease. I think it's important to remember that there are a number of people with atrial fibrillation from a number of different causes. And while they all manifest in the same phenotype, the same clinical picture of what we call atrial fibrillation, it's very likely that there are different subtypes within an umbrella diagnosis. I think a good analogy is that of fevers and infections. The phenotype, the clinical picture of atrial fibrillation, is like saying a patient has a fever. We can't simply stop there. We have to determine what is causing the fever, whether it be a pneumonia or a urinary tract infection or so on and so forth. AFib might just be a symptom of some underlying atrial pathology, and it's important when treating these patients to try and identify what's causing their specific subtype and how we manage their specific subtype. So with regards to causes, while we can't necessarily change the genome, transcriptome, and proteome as of 2018, one of the things we can address potentially is the environmental or clinical risk factors that lead to the development of atrial fibrillation. And there's a long list that's enumerated here. I won't necessarily go through all of them. Suffice to say that anything that promotes atrial or cardiac remodeling can result in atrial fibrillation. I think many of these are common nature to us, and because of this risk factor, the workup of a patient with new onset atrial fibrillation often looks to try and identify if these are in play. For example, an echocardiogram is commonly utilized in order to determine if there's a structural heart disease, electrolytes, thyroid levels, renal, hepatic function, and so on and so forth are commonly used. The one other risk factor that I'll make mention of is that of obstructive sleep apnea, which is a modifiable risk factor. In the last decade or so, we've become increasingly appreciative of the fact that obstructive sleep apnea goes hand in hand with atrial fibrillation. Many patients with OSA will have atrial fibrillation, and treating or modifying their OSA will result directly in a decrease in the atrial fibrillation burden. There are some patients who will no longer have AFib when their OSA is treated. I think it's really important for any patient that has atrial fibrillation to implement at least a clinical or symptom score screening for obstructive sleep apnea into the initial workup, as this is definitely a modifiable risk factor that is important in the management of patients with AFib. As for the exact mechanisms of AFib, again, it's heterogeneous because there are probably a number of different subtypes. The cartoon shown here tries to aggregate the different molecular mechanisms implicated in atrial fibrillation, and as you can see, it's a bit of a mess. We don't have a single pathway that results in the disease, and because of that, we don't have a single management strategy for it. We're still trying to appreciate the different interactions and subtypes. Again, atrial fibrillation is probably a downstream symptom of a number of different atrial or cardiac diseases. And so really understanding what is causing AFib in that specific patient is important. The actual electrical physiology is also somewhat unclear. We mentioned that, or we know that there are at least 3 different hypothesized reasons why we have this irregular circus movement type activation of the atria in atrial fibrillation. One possibility that many people have held on to is that there's actually a number of different reentrant circuits called the multiple circuit hypothesis that actually cancel each other out. Think of it as a number of different flutters that are really canceling each other out throughout the right and left atrium. A second possible mechanism for atrial fibrillation is that of a focal driver. So one myocyte or myocyte grouping that fires as an automatic focus. When it fires fast enough, long enough, or in the right conditions, that results in degeneration of the conduction outside of that focus, and that results in what we call fibrillatory conduction, or the pattern of atrial fibrillation that we see. The third proposed hypothesized mechanism is that of rotors, which are really a fancy way of describing spatial and temporal heterogeneities in the activation and repolarization of the atrial myocardium. Again, there are many different mechanisms, and the exact nature of them are important only to realize that different patients might have different mechanisms, and because of that, different treatments might be important. For example, patients who have focal drivers, eliminating or limiting that focal driver, that one group of myocytes that is causing atrial fibrillation, might be important. And we'll talk more about ways to go about that in the EP lab. Now, all of the mechanistic subdivisions and physiologic subdivisions are of little practical use when a patient comes in clinic with atrial fibrillation. The way that we schematically or systematically divide these patients is by the duration and the characteristics of their atrial fibrillation course. As we all know, there are paroxysmal, persistent, and long-standing persistent patients with atrial fibrillation. Paroxysmal are patients that have their arrhythmia terminate spontaneously or with intervention within 7 days. Episodes are often variable. Persistent have continuous atrial fibrillation for greater than 7 days, and long-standing persistent is greater than 12 months. Permanent atrial fibrillation is really a qualitative assessment that the patient and physician treating them are no longer trying to pursue sinus rhythm, distinguishing itself from long-standing persistent. The important clinical implication of this is that patients with atrial fibrillation may not always be in the arrhythmia. And so if a patient has risk factors for atrial fibrillation or symptomatology associated with atrial fibrillation, a one-time EKG is probably not enough to diagnose the arrhythmia, or better said, it's probably not enough to rule out the possibility of the arrhythmia. Longer-term monitoring with a Holter monitor, a loop recorder, event monitor, or even implantable recorders can be helpful to determine whether or not the arrhythmia is present. How aggressive one is in diagnosing really depends on the clinical suspicion and the clinical context. It's important to remember that all of these things are changing over time as well. Patients with paroxysmal atrial fibrillation, oftentimes over the course of 4 to 5 or longer years, will progress to persistent atrial fibrillation and ultimately may be forced to become permanent as therapies become less and less efficacious. The reason that these progressions occur is because the mechanisms of atrial fibrillation, as we just spoke about before, probably change over time. It's important to understand that identifying patients in the paroxysmal phase is oftentimes an opportunity to treat them if in fact treating their arrhythmia is worthwhile for their overall outcomes. And we'll talk more about when that may or may not be the case. With regards to the symptoms of atrial fibrillation, it's important to remember that AF does have significant morbidity and mortality. The symptoms of atrial fibrillation are highly variable. There are some patients who have no symptom whatsoever from the arrhythmia for years. There are some that will have disabling symptoms and have their normal daily activity discontinued with even a short paroxysm of atrial fibrillation. The reason that some patients feel it and some do not is still unclear. Obviously, the most commonly cited morbidity is that of cardioembolic stroke. There are ways to predict or to estimate patients' likelihood of developing a cardioembolic stroke using clinical risk scores like the CHA2DS2-VASc score or the CHAD score that many people are familiar with. But regardless of the other risk factors, we do know that all comers with atrial fibrillation may be at higher risk for cardioembolic stroke. Cardioembolic stroke from atrial fibrillation, unfortunately, are some of the worst types of strokes that exist for patients and obviously can result in a significant morbidity. There's also mortality associated with atrial fibrillation, even if one were to take into account statistically other risk factors associated in these patients, such as cardiovascular disease, obesity, hypertension, and so on and so forth. I think this probably represents that AF is a symptom, a downstream consequence that integrates a number of different negative cardiac remodeling risk factors. So the clinical management of atrial fibrillation, we've touched on some of the aspects so far, but I think the first priority is risk factor management. As we said, there are different types of atrial fibrillation, and different types of atrial fibrillation require different treatments. Identifying what is driving the individual patient's atrial fibrillation is important. As we said, if they're a person who has sleep apnea, addressing that will be important in limiting the arrhythmia and certainly limiting the progression of the arrhythmia. It's really important, I think a step that's often missed, that when someone presents with atrial fibrillation, it might be a red flag that some of their risk factors are not adequately controlled. Maybe their hypertension is not as well as controlled as one would hope. Maybe their other structural heart disease, such as their mitral regurgitation, is worse than appreciated. I think the risk factor management is certainly a priority that one must take into account when first encountering an AF patient. The second priority, as we mentioned, is cardioembolic stroke. As we said, and I won't spend much time on it, there are a number of different ways to predict when cardioembolic strokes are more likely based on the clinical picture. Based on the risk of anticoagulation, which is our most common treatment for atrial fibrillation cardioembolic stroke, we somewhat get a inflection point where the risk of the blood thinner is now less than the risk of stroke. This is, of course, a bit of a moving target based on the fact that anticoagulation has changed dramatically over the past 20 to 30 years. And so because of that, I think it needs to be constantly evaluated. The risk of stroke is not zero, no matter how low of a CHA2DS2-VASc or CHAD score patients have. It does increase certainly, but it never becomes zero. So it is a discussion that should be had between patients and physicians. The guidelines are somewhat variable, but largely recommend anticoagulation using vitamin K antagonists like warfarin or Coumadin, or novel oral anticoagulants that we're all familiar with, apixaban, dabigatran, rivaroxaban, and so on and so forth. There are other strategies. The role of aspirin has largely fallen by the wayside due to a small, if any, efficacy. The role of dual antiplatelet has shown to be unclear in many patients with a considerably high bleeding risk, often in the same ballpark of other anticoagulants, although it may be reserved for some patients. There's also been an increase in the utilization of non-pharmacologic anticoagulation or non-pharmacologic cardioembolic reduction prophylaxis via the use of left atrial appendage occlusion or excision, occlusion occurring non-invasively in the EP or cath lab, excision occurring in the OR, oftentimes thoracoscopically by a cardiac surgeon or a thoracic surgeon. Again, the algorithms to try and say where the inflection point is, where an oral anticoagulant is now advised, is somewhat variable. The role of aspirin is somewhat variable. It needs to be individualized for the patient. I think it's important to remember that the field is changing. What we used to believe the case in terms of how risky or having an anticoagulation was, or how risky not having an anticoagulant was, is changing the better and better anticoagulants get. Strokes from atrial fibrillation can be devastating, so even a quote-unquote low-risk patient, a real discussion should be had with them, the family, and the physician about what the best management strategy is. Now, the third priority after those first two risk factors and cardioembolic stroke prophylaxis are managed is that of what to do with the arrhythmia itself. And in actuality, this is oftentimes the first thing people think of, but I think it's important that we put it down to number 3 because oftentimes it's not as pressing of an issue as the first two. In broad strokes, there are two major strategies. One is rate control, which is used to simply slow the ventricular rate down using beta blockers, calcium channel blockers, or digoxin. Other times using AV nodal ablation or a ventricular pacemaker to try and decrease the ventricular rate. The second broad category of electrical management is rhythm control, which means using some strategy, an antiarrhythmic drug, or other strategy, ablation, surgical procedure, to help maintain sinus rhythm. Now, as we all know, there's a debate between, quote, rhythm and rate control. And in large part, rate control has been associated with similar rates of mortality and morbidity, which means that the actual electrical rhythm is not something we should focus on for the classic morbidity of cardioembolic stroke. Now, we all are familiar with the landmark trials, AFFIRM and so on, that suggested that rate control is just as good as rhythm control. The one thing I'll point out is that these studies were done a number of years ago using antiarrhythmic drugs to try and achieve rhythm control and using anticoagulation strategies that in large part are no longer clinically used. Antiarrhythmic drugs have poor efficacy, poor tolerance, and frank toxicities, meaning that at least part of the lack of benefit of the rhythm control arms in many of these trials possibly is related to toxicities from the antiarrhythmic drugs. But because of this large and relatively robust literature database, the people who actually get rhythm control are people who fail rate control, people who are symptomatic in atrial fibrillation, people who, no matter how much you rate control them, will still feel unwell in the arrhythmia. Then, of course, for symptom benefit, one would want to convert them to sinus rhythm. But because of the reason that I mentioned, there might be increasing indications. If our antiarrhythmics are not good, is there other reasons to convert someone to sinus rhythm? This slide here represents the mixed effects of antiarrhythmic drugs. Ostensibly, whatever drug we use to try and maintain sinus rhythm has its effect on target and off target. They can be classified based on the ion channel that they predominantly block, but there are a number of other side effects that can also be seen from a number of these drugs. The way that the drugs work, in large part, are to prevent atrial fibrillation via increasing the cycle length of a putative circuit within the heart. The antiarrhythmics have different mechanisms, different toxicities, and different interactions with other medications. It needs to be individualized for the patient. In general, there are some that are better and some that are worse. As we all know, amiodarone is one of the strongest antiarrhythmics in terms of the probability of retaining sinus rhythm. That being said, as we all know, amiodarone is one of the strongest antiarrhythmics with regards to toxicity. From an EP perspective, we oftentimes will start patients on quote-unquote weaker drugs that have less likelihood of success, but also less likelihood of harm. And patients who continue to need higher or stronger doses of the drug will sometimes be then converted to stronger drugs that have a higher likelihood of success, but then again, a higher likelihood of potential harm. Now, there has been a suggestion recently in a number of different trials that actually the commonly held dogma that rate and rhythm control are just as good is no longer the case. That maybe there are some populations like heart failure, like the young, that rhythm control is better. So what's changed? Were those original trials worse than they are now? Was there something wrong with them? The answer is probably no, but we are getting new data in the rate versus rhythm control debate because the way we're rhythm controlling people is no longer solely by antiarrhythmics. What we're doing now is rhythm controlling patients by catheter ablation as well as infrequently surgical procedures. The way that catheter ablation works is by, as we discussed, eliminating the focal source of a lot of the fibrillatory conduction. What was identified a number of years ago is that the pulmonary veins are likely one of the most common area for fibrillatory conduction to occur from. So catheter ablation works in large part, or at least the hallmark of it for atrial fibrillation, by electrically isolating the pulmonary veins. This allows for an option of rhythm control without the toxicities associated with long-term antiarrhythmic drugs. And in these trials that use rhythm control via catheter ablation, we're seeing pretty good reduction in the burden of atrial fibrillation, better with paroxysmal, who are earlier in the disease, than persistent, who are later in disease. And we're also seeing that these patients may, at least in subsets, do better than rate control. It's an evolving field, but I think that overall for atrial fibrillation, we're learning more and more about the disease and more about how to individualize it, potentially using catheter ablation as a way to help maintain sinus rhythm. Now, one cousin of atrial fibrillation is atrial flutter. Atrial flutter is a large reentrant circuit that occurs predominantly in one anatomic location, or confined by one anatomic location. There are a large number of different flutters, but it's largely defined as typical atrial flutter versus atypical atrial flutter. The reason that we use the term typical and atypical is that typical atrial flutter will have a characteristic pattern on the surface electrocardiogram, and that implies that the arrhythmia is confined by the right atrium using a small island or isthmus of tissue between the IVC and the tricuspid annulus. Now, the reason this is important is because this is an area of the heart that's readily amenable to catheter ablation, meaning that typical atrial flutter, when it is seen, can be relatively straightforward treated by catheter ablation between the tricuspid annulus and the inferior vena cava. Atypical atrial flutter is the same concept, a large circuit going around and round, but going around and around other locations in the heart, potentially the left atrium, potentially the SVC, so on and so forth. And really the term atypical implies, at least to an electrophysiologist, that it is not a straightforward, simple catheter ablation, meaning that other strategies should be employed. Now, atrial flutter, both typical and atypical, often run hand in hand with atrial fibrillation. What we've learned from a number of patients is that typical flutter, oftentimes origin is atrial fibrillation that for some reason organizes into atrial flutter. In fact, when atrial flutter breaks on its own spontaneously, a lot of the times it'll break into atrial fibrillation. So I think it's a overlap condition, oftentimes treated with a similar anticoagulation and risk factor management strategy because it overlaps. The electrical management is somewhat unique based on how troubling the arrhythmia is, but I think certainly one would want to treat them or think about these patients, with of course some exceptions, in largely the same bucket. Now with the last few minutes, we'll talk about other arrhythmias that result in a tachycardia from above the AV node. Now, unlike atrial fibrillation, these tachycardias are often regular, meaning that the ventricular rate, or at very least the atrial rate, will occur at a regular interval. The three major mechanisms for this are atrial tachycardia, AV nodal reentrant tachycardia, and AV reentrant tachycardia. They occur in varying frequencies. AV nodal reentrant tachycardia is by far the most common. ORT, or AV reentrant tachycardia, is the next most, and atrial tachycardia is by far the least. Atrial tachycardia occurs when there is a single site in the heart that decides to fire. And these group of myocytes can do so based on a number of different mechanisms, whether it be a triggered activity within a myocyte's cellular chemistry, whether it be automaticity, or whether it be a small actual micro reentrant circuit. Regardless, this focal area starts to fire. If you think about it, sinus tachycardia is actually a type of atrial tachycardia. It is a group of cells that decide to fire. It just so happens to be physiologically normal in many conditions, but it also can be physiologically abnormal in what's called inappropriate sinus tachycardia. Sometimes there's not just one site, but a number of sites that fire, and these competing sites can result in multifocal atrial tachycardia. This is often seen in conjunction with pulmonary disease, where a number of different sites start to go. This is a spectrum to atrial fibrillation. The reason being is that one of the most common sites where an atrial tachycardia can come from is the pulmonary veins, which we already spoke about oftentimes being the source of a rapid arrhythmia that results in atrial fibrillation. So it's a spectrum, but in large part, atrial tachycardias occur in younger patients who don't have altered, damaged atrium that result in atrial fibrillation. The far more common regular form of supraventricular tachycardia is AV-NRT, or AV nodal reentrant tachycardia. This occurs as there is a phenomenon known as dual AV nodal physiology, meaning the AV node actually has at least two different pathways that go from the atria to the His bundle or the ventricle. In actuality, it's probably more of a cloud of cells, a continuous spectrum, but at least schematically it's easier to think about as two separate pathways. AV nodal physiology is under constant alteration by the rest of the body, the vagus nerve, the clinical condition, and so on and so forth. But with the right condition, what can happen is that the atrial signal going down the AV node to the His-Purkinje system can get into a situation where it starts to loop itself within the AV node itself. And because of this, the atrium and the ventricle are more or less activated simultaneously. This gives retrograde P waves that often occur within or at the very tail end of the QRS. Management of this varies depending on the symptoms that it results in. Again, this regular paroxysmal supraventricular tachycardia often occurs in patients who have otherwise normal hearts and who are otherwise healthy. So management really depends not in terms of morbidity and mortality, but in terms of symptom management. Anything that can influence the AV nodal physiology can help limit the arrhythmia. Beta blockers, calcium channel blockers can be used, although they're difficult for sometimes young patients to tolerate. We can influence the AV nodal physiology in the EP lab by ablating, cauterizing, or eliminating the slow pathway preferentially, allowing for only one pathway for the heart to conduct from the atrium to the ventricle. This is one of the fundamental procedures done in the EP lab with relatively good success rates and relatively low morbidity. The final regular paroxysmal supraventricular tachycardia is AVRT. This involves the use of an accessory pathway where the conduction goes down the atrium to the ventricle through the AV node and then back up an accessory pathway. This is also known as orthodromic reentrant tachycardia. It goes the right way down the AV node and back up an accessory pathway. A far less common but also seen variant of this atrioventricular reentrant tachycardia is the opposite circuit, where it goes down an accessory pathway and back up from the ventricle to the atria of the AV node. This is known as antidromic reentrant tachycardia. If the accessory pathway is seen on the surface EKG in sinus, meaning that in sinus it goes down the AV node as well as down the accessory pathway, that is known as manifest preexcitation. And that is, with only an EKG, gives a diagnosis of Wolff-Parkinson-White syndrome, or pattern, Wolff-Parkinson-White pattern. If associated with clinical symptoms, that gives Wolff-Parkinson-White syndrome. The management of this, again, depends on the symptomatology. In rare cases, an accessory pathway that conducts in a manifest manner or antegrade can result in dangerous arrhythmias, especially if the characteristics of the pathway allow for rapid conduction. You can imagine a situation where if a patient is in atrial fibrillation with rapid conduction down an accessory pathway, if the accessory pathway results in rapid activation of the ventricle, that could mimic ostensibly ventricular tachycardia or ventricular fibrillation. Most accessory pathways are not able to conduct that fast. They have decremental properties, just like an AV node. But if someone does have manifest preexcitation, oftentimes risk stratifying their pathway physiology can be helpful in terms of determining exactly how to treat it. Otherwise, patients are largely managed based on their symptoms. So in summary, atrial fibrillation is the most common arrhythmia and is associated with morbidity and mortality. In order to manage this morbidity and mortality, one must take into account the risk factors that are associated with that specific subtype of atrial fibrillation that the patient has, anticoagulation, which again must be individualized for the patient, and rhythm management, which also must be individualized for the patient. Rhythm management is an evolving field with the advent of catheter ablation, and the jury is still out in exactly who, if anyone, would benefit from that compared to antiarrhythmic drugs and compared to simple rate control. Paroxysmal SVTs often are associated with less morbidity and mortality, although there are some exceptions, and are derived by three common mechanisms, AVNRT being the most common, atrial tachycardia being least common, and really a spectrum with atrial fibrillation, and finally AVRT. They are often symptomatic, and so management strategies are based on improving symptoms and less commonly associated with mortality, although there are certainly some rare but notable exceptions to that. So in terms of questions, a 70-year-old woman with type 2 diabetes and rheumatic mitral stenosis is evaluated for dyspnea and fatigue. She has a history of AFib that has resulted in these symptoms in the past. She has had successful cardioversions, most recently 2 years ago. She has hypertension, controlled with medication. She also has mild LV dysfunction related to coronary disease and a history of an MI. Her medications include atenolol, lisinopril, aspirin, atorvastatin, and insulin. Her exam demonstrates an irregular rhythm with a heart rate of 78 beats per minute. Blood pressure is 130/80. The cardiovascular and pulmonary exams are otherwise unremarkable. What medication should this patient relieve as 3 to 4 weeks before cardioversion? Warfarin is the correct answer here. Prior to cardioversion, anticoagulation is important to prevent cardioembolic risk. In patients with rheumatic heart disease, warfarin is thought to be preferable to other oral anticoagulation. Dual antiplatelet therapy is inferior to warfarin for anticoagulation in atrial fibrillation for patients who can tolerate an anticoagulant. Question 2. Which one of the following statements about atrial fibrillation is correct? Lone atrial fibrillation is a common cause of atrial fibrillation. Atrial fibrillation is more common in younger women than in older men. Anticoagulation is not indicated in patients who have non-rheumatic heart disease and atrial fibrillation. Many patients who have atrial fibrillation do not require antiarrhythmic therapy. Atrial fibrillation is a serious problem and serious and common problem in patients with AV and RT. Lone atrial fibrillation is a relatively uncommon problem. While it's a term that was more frequently used in the past, we're more and more appreciating that atrial fibrillation occurs in the context of comorbidities. Atrial fibrillation is more common in elderly and more common in men at all age groups. Atrial fibrillation anticoagulation is indicated in non-rheumatic heart disease based on cardioembolic risk, the CHADS VAS score. Many patients with atrial do in fact not require antiarrhythmic therapy, as rate control is a common and acceptable strategy. And AV and RT, while it can be associated with atrial fibrillation, is not commonly seen in that population. So the correct answer is that many patients who have atrial fibrillation do not require antiarrhythmic therapy. Some references for further reading are listed here, a collection of review articles and some of the seminal papers describing the disease.